Dear colleagues, thank you very much for this kind invitation to present some information on gynecological tumors in adolescent and young adults. I'm really honored to participate in this training program, and I'm really curious for your feedback and for your questions. I want to start that there's no conflict of interest, but that the German Rare Tumor Registry, the STEP group, is funded by the German Childhood Cancer Foundation, and the European Cooperative Study Group on Pediatric Rare Tumors is funded by the European Commission, but I will come to this later on. So talking about cancers in adolescent and young adults, you will see that breast cancer is one of the most common diagnoses. This will be in a different talk. I won't be talking about this. And what I will be talking about, the gynecological cancers, apart from breast cancer, are in this big group of heterogeneous rare tumors. Looking at the data from the US in more detail, again, you will see that in this age group, the breast cancers are the most frequent cancer type. The second most frequent gynecological cancer type are those of the cervix and uterus. Having said that, it's the classical uterine corpus carcinoma is very rare in this age group, but the cervical cancer is an issue. So I will give a very brief note on that. But otherwise, I will be talking about the germ cell and the other ovarian tumors. And these are tumors that you may find in all the age groups, from early adolescents up to middle-aged adults. And looking at the data in gynecological cancers, it's all at the bottom line. And one remarkable thing about here is during this time period, you see a peak on Kaposi sarcoma, just by the way, and this is during the HIV pandemic. But the cancers I will be talking about will be those in this bottom line. So we are talking about very, very rare tumors. And there's one common theme about the very rare tumors is that they have something in common across all entities. One common theme in very rare tumors is that they are all very rare. We have a low incidence and a high heterogeneity. So in the German registry for very rare tumors, we are seeing more than 50 different histological diagnoses. So it's very difficult to have a pattern recognition, to diagnose the tumors and to identify risk factors because just the numbers are too small for statistical analysis. So the therapeutic strategy is a very individual one, and there's no really good standard of care. And with the European and international cooperation, we've started to develop something like at least consensus guidelines and recommendations. And the other thing is that for the very rare tumors, there's a lack of structures. So they're under-registered. There are no therapeutic trials, no randomized trials. It's statistically impossible, but there are more and more clinical registries, but we have very little funding for clinical and translational research in very rare tumors. So these are common themes. And this is also true for the very rare gynecological cancers. But if you start building structures, if you start building registries, you will see more of those. And this is shown to you by this slide, just focusing on the very rare ovarian tumors that we registered in the German registry for germ cell tumors and for the rare tumors. And with building structures, with building registry and consultation process, you will see more and more of these tumors. While we have seen maybe 1 or 2 tumors a year, now we are seeing more than 10, sometimes 15 tumors a year. So it's really worth building structures. And one of the structures I would like to present to you, as this is a European meeting, is the European Cooperative Study Group on Pediatric Rare Tumors. Because we know if you work on frequent cancers, you have to do randomized trials, but if you work on rare tumors, you may find friends. And so this is what we do. We work together, we are networking, we are building structures, and you're heartily, cordially invited to join us and to bring more young input into the group. I will start with a very brief comment on cervical cancer, and this is some data from the Brazilian from Brazil, because it shows you that cervical cancer arises, but it's a problem, especially in countries without HPV vaccination program. And most of the tumors are diagnosed at an early stage as in situ carcinoma. But if you have a region like here in the north of Brazil, where you have weak medical structures, you will see more invasive carcinomas. So cervix cancer in the adolescent and young adult age group is an issue of HPV prevention through vaccination and of early recognition by screening programs. So this is, I hope that these issues are established in the European Union so that we will have rare cervical cancers, so that the incidence will be declining with the HPV vaccination programs, that we will also recognize the tumors at an early stage. Moving on to ovarian tumors, most of the pediatric oncologists will just think if it's an ovarian tumor, it's either teratoma or germ cell tumors. But there are more tissues in the ovary. It's not only germ cell tumors, but also the whole stromal tissue and the epithelial layer. So you will see different histological diagnosis because you have a different pattern of histogenesis. And looking at the germ cell tumors, they may be presenting as teratoma, as malignant germ cell tumors, and as a precursor lesion, which is gonadoblastoma. If you look at the stromal tissue, these are the tumors that are called sex-cord stromal tumors with different histological diagnosis. And the epithelial layer will give rise to the benign lesions like cisadenoma and classical ovarian carcinoma, and the borderline tumors, which are cisadenoma with some proliferative spots just on the way from cisadenoma into ovarian carcinoma. And the last but very rare group is the group of small cell ovarian carcinoma hypercalcemic type, which is a tumor of unknown origin. And this will be the last one I will be talking about. Looking at the frequencies, you will see that the germ cell tumors may arise both in adolescent, also in young adulthood, but that the incidence of epithelial tumors, especially carcinoma, rises with age. So ovarian carcinoma is a problem of the adult and especially of the elderly. And also, if you look at these, some 50 sex-cord stromal tumors over a 5-year period in the United States, this shows that there's a high proportion of under-registration. If we have 10 to 15 a year in Germany with a smaller population, there must be under-registration. Looking at the genetic data, we should know that the malignant germ cell tumors may be associated with sex chromosomal aberrations like Turner syndrome or presence of Y chromosomal fragments. And this may have a phenotype of testicular feminization or Swyer syndrome with streak gonads. And these are the tumors that are typically associated with gonadoblastoma. But if you look at malignant germ cell tumors, you will see sex chromosomal aberrations more frequently than you would expect. Some types of sex-cord stromal tumors may be associated with DICER1 syndrome. This is the syndrome that also includes pleuropulmonary blastoma and also thyroid disease like goiter or even thyroid carcinoma. And the epithelial carcinoma, ovarian carcinoma, may be associated with genetic predisposition, for example, at the breast cancer genes. And the small cell ovarian carcinoma may be associated with SMARC of A4 aberrations. And this may also run in families if you have a germline mutation. I won't be talking about the whole biology of germ cell tumors because this would fill the whole time of my talk. But I would like to point out that this is maybe the most important table for germ cell tumors, that we have an association between the histological diagnosis, tumor markers, and the response to chemotherapy. So typically teratoma, be it mature or immature, are not associated with tumor marker secretion, and they are irresponsive to chemotherapy or radiation. So for teratoma, you need the surgeon. For seminoma, these are tumors which are highly sensitive to chemotherapy and radiation. So in early trials, these patients have also received irradiation in case of lymph node metastasis. Now they rather receive chemotherapy, and they're very well responsive. They're tumor marker negative, typically. They may have some small amount of beta HCG. And yolk cell tumor typically associated with AFP, choriocarcinoma with beta HCG secretion. And if you have a mixed tumor, you will have AFP and beta HCG secretion. So, and you may guess from this, what's the histological diagnosis and whether this is one with a very good prognosis, which is seminoma or dysgerminoma, or whether it's one where you need more intensive therapy like yolk cell tumor or choriocarcinoma. Starting with the patient, this is a typical presentation of a teratoma. An 11-year-old boy, 11-year-old girl who presented with abdominal swelling, and you see the MRI that it's a combined cystic and solid tumor. And if you take the tumor out, it's a cystic appearing, intact, encapsulated tumor. And if you open the capsule, you will see here some brain-like tissue, and it's a typical teratoma. And the ovarian teratoma have a very peculiar biology, that these are post-meiotic tumors. They have 46 chromosomes, but they have the same chromosomal set twice. So it's an isodisomic tumor. They are mostly cystic. The tumor markers are negative. And if you take the tumor out with the ovary or even with organ-sparing resection, the overall survival is 100%. But if you have incomplete resection, and this is some old data from my old academic teacher, Professor Goebel, if you have incomplete resection, you may see a few relapses, but the overall survival is still good. And also, if you look at the British data, the overall survival in immature teratoma and in mature teratoma is 100%, but in immature teratoma, you have a 10% risk of relapse. In mature teratoma, the relapse risk is less than 3%, so it's very low. So ovarian teratoma, very good prognosis, but the surgeon and the surgical resection is an important determinant. Another girl also presented with abdominal swelling and abdominal pain, negative tumor markers, and you see that this is more solid appearing tumor in the MRI. Also, if you take it out, you see it's a solid tumor encapsulated with a small rupture at this place. So this was a dysgerminoma. And looking, so the question is if it's a organ, the tumor that is delimited to the organ, how to proceed. And this is the data from the German study. We have been looking at the stage 1 tumors. You know that the International Gynaecological Staging Figure System says that all the tumors that are limited to the ovary are stage 1 tumors, 1A completely resected, 1C with preoperative or intraoperative rupture or with malignant ascites. So if you look at the figure 1 patients, we see a progression risk of 33%. So one of three patients may have a recurrence. If you give chemotherapy, the progression risk is reduced to 10%, but this is a dose reduced chemotherapy, only 2 cycles, but the overall survival is very good. Looking at stage 2 to 4, which are the ones with peritoneal spread, lymph node metastasis or distant metastasis, you have 4 cycles of chemotherapy and you have a very good tumor control with only a low risk of dying. So the most problematic patients are the ones with FIGO stage 1, because you have to decide, shall I choose watch and wait therapy or chemotherapy? And looking at these data in stage 1, you see that the progressions are mostly seen in those patients who have York-sick tumors or malignant germ cell tumors, and you see them more frequently in the elderly group than in the young group. So what happened to Anna? Anna, after 2 years, almost 2 years, she had a progression at the typical lymph node. It's a right ovarian tumor, so it's a para-aortic lymph node metastasis, but we gave chemotherapy, and after 2 cycles of chemotherapy, we saw a very good shrinkage. The lymph node was taken out. It was almost completely necrotic, and Anna is doing fine. She's a young adult now. And this is a typical course. And looking at the American data and at the German data, we know that 1/3, maybe 1/4, in some studies up to the half of the patients may have a progression, but almost all are cured with adjuvant chemotherapy. So it means that 1/3 of patients needs more chemotherapy, but on the other hand, 2/3 don't need chemotherapy. So the question is it the glass half full or is it the glass half empty? And the general strategy is that as we don't want to harm patients, that we now recommend in all stage 1, 1A and 1C, an adjuvant watch and wait strategy and no adjuvant chemotherapy. But the point that must be very clear is that if you have a patient and you choose watch and wait strategy, you must be very safe that there's a close follow-up and that the surveillance is really very tight. If the patient is not able to comply with follow-up, you should rather take the safe way and give chemotherapy. So what happens if you give chemotherapy to a stage 2 to 4 tumor, or if you have a tumor that relapses, you give chemotherapy and there's a second relapse? We know that there's a good second chance, because if you take the patients who have a poor response or first relapse, we know that if you intensify chemotherapy with cisplatin-based chemotherapy in Germany, we would add regional hyperthermia. In other countries, you would add another resection or irradiation, that we have a very good chance of a second or third remission. So we have a good salvage therapy, and this is another reason why we would take the risk of having a progression in stage 1 tumors, because we know we have a good second chance with the delayed chemotherapy in these cases, and we would even have a good third chance if they relapse after the chemotherapy. So taking these data together, we would say that in all ovarian germ cell tumors, you should always measure AFP and beta-HCG prior to surgery. In teratoma, you should go for ovarectomy or even ovarian sparing tumor resection. In stage 1, you would go for ovarectomy and choose a watch and wait therapy. You should know surveillance is important, and that you have a good and close watch and wait strategy. In stage 2 and 3 tumors, you would go for adenectomy and chemotherapy, 4 cycles of chemotherapy, and there are several trials which are comparing cisplatin with a carboplatin-based chemotherapy. In the very advanced tumors, you would start with chemotherapy and do the resection as a delayed resection. And you may ask for consultation, for example, at the German Mackay study, and they're very happy to take your questions. So this is the risk stratification as I explained to you, and you see that the low-risk patients are watch and wait. The other ones have a 2 cycle of chemotherapy, and the high-risk patients have a 4 cycles of chemotherapy. And in the very, very, very high-risk patients, we would choose a dose-intensified chemotherapy, but this is maybe less than 5% of all patients. So this is a very rare constellation. In the European group, we have worked together with the European Society of Gynaecological Oncology, and we have also developed recommendations for follow-up in these tumors, and this has been published in Lancet Oncology a few years ago. And you see that you should go for long-term follow-up, because we know that there's a up to 5% risk that there will be a metachronous tumor in the contralateral ovary. So you really have to have a long-time follow-up. So now I'm changing my subject, and I will continue with the sex cord stromal tumors, which are arising from these tumors in the middle, or the granulosa cells that are supporting the germ cell development. And these tumors are not as rare as it has been discussed so far. Looking at the last 20 years, we've seen 1,000 germ cell tumors and teratomas, but we've also seen 150 sex cord stromal tumors in the same period of time. And we also see the other tumors. So if you are registering very rare ovarian tumors in Germany, you see at least 10 to 15 tumors a year, which is not so rare. And if you do it over a long period of time, you can really arrive at meaningful recommendations. So we start in 2003 with an analysis of ovarian sex cord stromal tumors. And one important thing is that overall survival is very good, but event-free survival is also very good, but there's only a small gap between event-free survival and overall survival. So you only have one good chance, and you don't have a good salvage strategy. The other point is that stage is important for prognosis. And if you look at stage 1C, intraoperative violation, which means pillage, is not associated with poor outcome, but preoperative rupture or malignant ascites is associated with poor outcome. So these are the ones that you have to treat right away. Looking at the long-term outcome, we see that only one of the relapses achieved long-term remission. So you really have only one good chance. You have to make the right decisions right away at the beginning. We have collected more tumors since then, and half of the tumors have been juvenile granulosa cell tumors. The second big group have been the Sertoli Leydig cell tumors, and I'm presenting one patient, which was a 14-year-old girl with a Sertoli Leydig cell tumor and a big ovarian tumor, which looks a little bit like grapes. You see the intraoperative situation with the uterus and the ovary and the big solid tumor. This patient has been resected, followed up. She developed a second tumor in the contralateral ovary 2 years later, and she developed a thyroid cancer another 2 years later. So you may guess that this is a DICER1 mutation associated tumor. And looking at those Sertoli Leydig cell tumors, the overall survival of the whole group is not that bad, looking at the European data, but we have quite a substantial risk of events, and a part of the events are true relapses, and the other part are the ones that are metachronous contralateral tumors, and these are typically the events that develop after a longer follow-up. You see that the last development of a metachronous contralateral tumors occurred after 4 years, so you really need a long follow-up. Looking at the very rare at the more frequent juvenile granulosa cell tumors, you'll see that we have adopted, and these are unpublished data from the German series. You see that we have adopted the strategy from the 2003 analysis very clearly. We have not given chemotherapy to 1A tumors. We have not given chemotherapy to those tumors with only intraoperative spillage, but we've predominantly given chemotherapy to those with a preoperative rupture or malignant ascites. And looking at the outcome, you see that if you give chemotherapy to these tumors with preoperative ascites, a preoperative rupture or ascites, malignant ascites, so that you have a very good tumor control with adjuvant chemotherapy. The peculiar thing is that we have now seen a few relapses in stage 1A tumors, even after chemotherapy, but these have been very distinct tumors with a high proliferation rate, extremely high proliferation with a poor level of differentiation. So these are probably biologically distinct tumors. So making very individual recommendations, you really need centralize knowledge on these tumors, and you have to use consultation structures. You have to talk to us so that you make the right decisions right away. Looking at all these sexual stromal tumors, event-free survival is very good, and overall survival, progression-free survival, even better. So that's the good news. Going on to the epithelial tumors, you may distinguish those who are cystadenoma, the benign tumors or borderline tumors. These are typically cystic tumors, sometimes very large. So the largest tumor I know of has been almost 5 kilograms. But you also see ovarian carcinoma, which have more solid components, which also may be very large. And you may see lymph node metastasis of these tumors. And going through the different histological groups, starting with cystadenoma and borderline tumors, the cystadenomas are really benign tumors, and borderline tumors, you have more proliferative components, where you see proliferations of the epithelial layer. The good news is that most of the tumors are stage 1 tumors. All have been doing fine after watch and wait strategy. Only one patient had a local relapse, has been operated on a second time, but is now in second remission. So overall survival is almost 100%. One peculiar thing is that many of these patients had abdominal malformations of the GI or GU tract, but it may also be a selection bias that these tumors have been seen by pediatricians, and that then they have been diagnosed with the tumor, and then they have been in closer contact with the pediatric oncologists who reported the patient to our registry. So while the other ones have been in gynecological departments and they never report to pediatric oncologists. Looking at ovarian carcinomas, very rare. I guess that most of the tumors have been seen by gynecologists. In our group, all have been highly differentiated. One was a tumor within a borderline tumor with a focal carcinoma differentiation. All have been stage 1A, watch and wait, and all in CR. But we know of one patient who had a small cell carcinoma with stage 3 peritoneal metastasis, who was very refractory and died in progressive disease. So these tumors may occur, but probably we don't see them in pediatric oncology departments. And now I'm really getting to the last group, and this is a very nasty one, because this is the ovarian small cell carcinoma hypercalcemic type, and it's defined by a specific genetic diagnosis, MARCA4 mutation, and the literature says that is a very poor prognostic tumor. And in the first publications, the survival rate of adolescents with stage 1A, completely resected non-metastatic ovarian small cell carcinoma hypercalcemic type, was less than 10%. So it's very, very, very aggressive tumor. Now we have a good marker because we can diagnose the patient by this genetic screen for MARCA4 mutation. So this brings the tumors in close proximity to the rhabdoid tumors. But this is a genetic marker which helps with diagnosis. We have done an analysis of these tumors of 11 patients in 2006. And we saw that 5 patients survived after high-dose intensified chemotherapy. And the concept since then was that we gave 6 cycles of cisplatin ifosfamide adriamycin and a consolidating high-dose chemotherapy. This regimen is a little bit different from germ cell tumors, but it shows that it's more proximity to the rhabdoid tumors who also receive adriamycin. And looking at the patients, you see that 5 patients here have been in complete remission after high-dose chemotherapy. 4 patients have been, 4 or 5 patients have been in remission after high-dose chemotherapy. So it's a chemosensitive tumor. You need high-dose chemotherapy. It's poor prognostic, but it's curable, also in advanced stages. And we've had a very strong discussion with the European Society of Gynaecological who said that because these tumors are so prognostically unfavorable, because whoever survives this never gets pregnant, that you have a total surgery with hysterectomy and everything out. In pediatric premenopausal women, I would advocate to have a fertility sparing surgery, because we've seen 2 patients who indeed survived, achieved complete remission, got pregnant, and had a delivery. So please stop your gyneco-oncologist to do total surgery. They have a chance of surviving and of getting pregnant. So all in one slide, germ cell tumors, most frequent ones are the teratoma with watch and wait strategy after surgery. Malignant germ cell tumors are treated according to stage, watch and wait strategy versus PAY in or PEB regimen. In the sexual stromal tumors, most of the patients will be eligible for watch and wait strategy, advanced stages also with PEI. Epithelial carcinomas, again, most of those are watch and wait strategy. In classical ovarian carcinoma, you would give carboplatinum Taxol, and ovarian small cell carcinomas, even in low stage, always chemotherapy and high-dose chemotherapy. Always go for aggressive strategy. So having said this, it's networking, not working. You really have to come together for these rare tumors. You have to exchange experience. You have to use consultation network. And the last slide is the invitation. If you have these tumors, just contact me by email, or even better, we have a European-funded clinical patient management system within the European Reference Network on Pediatric Oncology, and you may register here. You will be able to present the case. You will be able to discuss with the patient with experts in the field. You will be able to discuss the patient with surgeons, and you get a very good online consultation. So you're cordially invited to use this tool. So I hope that I have brought some new information to you on rare gynecological cancers, and I'm very happy to take your questions. You may contact me by email or whenever we meet at the next SciUp Europe meeting. Have a good day. So